It's an honor to be selected. It's an honor to present to you. Thank you, Dr. Weiner. We have no disclosures. So let's review what we know. We know that breast cancer is the most common malignancy among women in the United States. An estimated 1 in 8 women will develop a breast cancer at some point during their lifetime. We know that the number of new cases, what we call burden, in the United States is expected to increase. And in our work, we have pointed out that the incidence rate, the number of cases per 100,000 women in a year, of invasive estrogen receptor positive tumors are increasing, and the incidence of estrogen receptor negative tumors are decreasing. So for this study, we wanted to take a look at what is the future. What's the incidence going to look like? And how many new cases are expected to be diagnosed in the United States going forward? And we wanted to get a very detailed snapshot of this future scenario, breaking it down by ER status, by invasive or in situ behavior of the tumors, and by the age of diagnosis. So we developed a forecasting model for the United States. This is based on the National Cancer Institute SEER registry data, which is one of the best registries in the entire world, and included information from more than 500,000 cases. And we projected the incidence and the burden through 2030 by those groups I mentioned, by the ER status, by the behavior of the tumor, invasive versus in situ, and for different age groups. Now, in our models, we incorporated some effects that make breast cancer rates very heterogeneous. We incorporated effects of age, which reflects an underlying biology of the disease. We also incorporated what we call a year of diagnosis or period effects. So to give you an example, there's the famous Betty Ford blip. The First Lady in 1974 revealed her diagnosis and her treatment to the American people. And after that, huge numbers of women got examinations, and there was about a 15% increase subsequent to that. So that's a period effect. We adjust for those sort of effects. And finally, and very important, we adjust for what we call birth cohort or year of birth effects. So to give you an example of that, in my mother's generation, breastfeeding was not common. And in my generation, breastfeeding was very popular. Now we know that breastfeeding can have an influence on the rate of breast cancer. And there are many such factors involved, the lifestyle and how we live and what our circumstances are. And the net effect of all those together moves the cancer rates in a registry up or down according to what your generation is. And we can model those net effects in our models. Okay. So I want to review some data we presented in 2011. I think is very important. This graph is showing the incidence of ER-positive tumors in the United States from 1992 through 2010. On the x-axis, we have year, and on the y-axis, we have the rate of breast cancer per 100,000 women. And I've split this up by age group, and you can see that there's an interesting pattern in the over 50, that's the green and the purple, that's dropped there, and that's attributed to the drop in the use of menopausal hormone therapy. Now, importantly, when we analyze the trends in the observed data, you can see that already in the recent past, in the older age groups, there's been a significant increase in the incidence of estrogen receptor positive invasive tumors. And in fact, the incidence of this type is increasing in each of those age groups in recent years, or going back in the case of the younger age groups earlier. So these trends are driven by the cohort effects, and using all that information, we can model the future incidence. And what we forecast is that the future incidence will increase in each of those age groups. Now, over here, I want to take your attention to the right-hand graph. And here, the y-axis scale is different. This is showing the burden. So this is going from a SEER incidence and then using population data to estimate the number of cases in the entire United States. And so what we see on the right is now the burden broken down by age group and for all ages, where we can see that overall there's a rise. Now, in the oldest age group, the 70 to 84, our estimate is the incidence will rise about 0.5% a year going forwards. Now, in the whole population at the same age group for the burden, that curve is presenting a 4% per year increase. So one thing that's important to understand is that that's the fastest growing age group in the United States. So the number of people in that age group is growing 3.5% a year. So a large part of that increase is because the population is growing. The number of older people is growing. So our models can take those factors and put it together to give you a snapshot of the future number of cases. Now, this graph shows the same analysis, and it's on the same scale, so the data are kind of scrunched down. And this is new. This here is an analysis for in situ ER-positive tumors. Now, most of these cases, as you know, are diagnosed via screening mammography. And we're starting our data series in 2004 because that's when ER testing, and then it was reported into the SEER registry, became common for the in situ tumors. And the important point here is that as for the ER-positive invasive tumors, the incidence of the in situ ER-positive tumors is also increasing, and so too would be the burden. This is, the top panel is an update on our analysis of the rate of invasive ER-negative tumors, and you see there's declines in each age group we reported previously. And I've also shown here, I guess the graph didn't work. Yeah, you're looking at what I'm looking at. Yeah, so on the right-hand side, in the forecast part of the time axis, it shows that our forecast is that the incidence will also decline, except of course in the 30 to 39-year-old age group, which is more or less flat because that group isn't routinely screened. So consequently, based on those incidence trends, the burden of this type of tumor is also expected to be stable or decrease. And thank you for that. PowerPoint kind of messed up. But there is a burden, wasn't on the slide before. So going from the right-hand side to showing the burden for the top for the ER-negative tumors that are invasive, and the bottom for the in situ tumors. So we have stable or decreasing for that type of tumor. Okay, so putting it all together, all those groups, and adding everything up, our estimate is that the total number of diagnoses in the US of breast cancer, invasive and in situ, all types, will increase from 283,000 circa 2011 to 441,000 circa 2030. So that's a 50% increase. Now, it's important to understand that that increase reflects three different factors. First, it reflects the increasing population, the baby boom generation, of course. So there's more people, and more people, you have more cases. The second thing that contributes to that rise is that life expectancy is getting better. So women are living long enough to develop a breast cancer in their lifetime. And the third factor that contributes is the increases in the rates that I showed you, because those are cohort effects, and so those cohorts are developing cancers in the future, and so those increasing rates are also factored in. Now, I wouldn't get hung up on one number. There's a lot of uncertainty. And if you run some different models, you can get a range of 25 to 65%. But importantly, I think when you drill into it and you look at the patterns, I think there's some important signals. Our forecast is that in the future, breast cancer cases will be older. The fraction of cases 70 to 84, according to our models, will increase from 24% today up to 35%. Circa 2030. There'll be more ER-positive in situ tumors. We expect it will increase from 19% of all breast cancers diagnosed today up to 29%. And there'll be fewer ER-negative tumors, according to our forecast. We expect that will decrease from 17% of all tumors today down to around 9% in 2030. So our data do suggest some clues about what would we like to know going forward? What would be useful information to plan for a better future? So certainly I think knowing more about how to manage the clinical burden overall, but especially among women who are 70 to 85. I think it'd be very useful to know more about the natural history of these in situ lesions that are being diagnosed. We believe it would be very useful to clarify all the reasons for why estrogen receptor negative tumors are declining, because there may be a hidden prevention clue in that experience. And finally, it would be very useful, and something we certainly plan to do, to make future estimates for each race and ethnic group, because that level of detail could also be helpful. So thank you.
So this is a powerful and I think very important set of observations and predictions. I think it's intuitively obvious that as our population expands and our population ages, that certain kinds of cancers would be more prevalent, and that's sensible. We would like to see a reduced incidence because we've developed more effective prevention strategies, but those have remained very difficult to identify in this population. And so we are left with this dilemma. What I think is really critically important about this observation are two things. One is that there's a prediction of fewer estrogen receptor negative tumors, which I think does create great research opportunities. And secondly, that there seems to be an increasing shift towards earlier stages of cancer that are being detected. And that really creates major challenges for how do we deal with in situ breast cancers. Are they all going to need to be treated? If so, what will the criteria for treatment be? How will this be approached? Creates a really dazzling array of research questions that we can consider in the future that might help prepare us for a future that isn't really all that far ahead of us. It's only 15 years from now. So the one question I have is, this is a very powerful modeling strategy that you've identified. Is it relevant to other common cancers, do you think? Can we start gaining more information about what we might be expecting in terms of disease burden to prepare the healthcare sector for where the future areas of need are going to be?
Oh, thank you. That's an excellent question. Appreciate that. So one of the things that's most exciting to me is that these models are totally general. It's not a breast cancer model, it's a general model for cancer that puts together the SEER incidence, and it puts together population projections and puts them together in a novel way. Now, this year we published an analysis of forecasting for multiple myeloma, and we have a lot more projects that we've started and that we're planning to do. So yes, it is a tool that could be useful for other cancer sites.
Questions?
Nick Mulcahy, Medscape. Is DCIS breast cancer? Is it technically a breast cancer?
Yeah, that's an excellent question. Now, what we're doing in our models is forecasting the entity that called in situ breast cancers. So the cases are told they have a breast cancer, and those events are recorded in the cancer registry. And that's the entity that we're projecting. We have no information about whether it's a better or worse cancer on any individual basis in our analysis.
But the question is DCIS a cancer? And you keep calling it a cancer when, in fact, lots of people are saying it's not a cancer. And the end effect here is that you've grouped something that's potentially not a cancer with something that definitely is, invasive cancer, which gives a bigger set of numbers and seems more catastrophic, which contributes to the general panic about breast cancer, perhaps.
Yeah, the numbers are the numbers, and what this type of modeling does is it shows you the future implications if we do what we've been doing now and we diagnose the way we've been diagnosing now in the recent past, and we push that forward. That's all we can do with this type of approach. And that's really the purpose of it, because the idea is if you know there's going to be a lot of these tumors, and that gets to the third point, that would be great to understand the natural history. Because that's sort of your question. Well, if we knew more about the natural history, and that is sort of what's suggested by this study. It would be very useful to know that.
Okay, we have a question on the line. Real quickly, Matt Herper from Forbes magazine. Go ahead.
Hey, how is everybody? Could you explain quickly, do you have any information on what is causing the rates of incidence? And do you know what happens if you take those to the numbers, if you take those DCIS numbers out?
In terms of the first question, I guess it was about the changes in incidence. That's a great question.
Yeah, what's driving it?
What's driving? So presumably it's changes in circumstances and lifestyle. And we know that there's a lot of risk factors that are stronger for estrogen receptor positive tumors, and there's some that are stronger for estrogen receptor negative tumors. But that's not what our models are purposed to address. So the purpose of the model is to make a forecast of the cases we expect to see. There's no information about the risk factors. So that is an excellent question, and these studies can help to highlight areas where we would like to know more of what epidemiologists would call the etiologic fraction. So how much of that increase is due to one cause or another, or one risk factor. But that's a topic for future research, different types of research than ours. In terms of your second question, we didn't specifically do that, but because of the modeling approach, we could. So that's an excellent question.
Next question, Charlie.
Charles Bankhead, MedPage Today. Given that age is a principal risk factor for all types of cancer, and that there are more and more women becoming postmenopausal as the population ages, if you take that into consideration, are the projections outpacing the demographics that are associated with breast cancer? Is there anything else that might be contributing to this above and beyond some of the demographic and social factors?
Well, as I said, so the increase reflects the three factors, which is the rising number of elderly people, which is our population structure, the improved life expectancy, and the established increases in the rate of ER-positive cancer. So all those three things go in to contribute to the forecast. So I guess just clarify the point of your question, please.
Well, are the numbers, I guess, given all that background, are they particularly surprising that there's going to be continued increase in the number of ER-positive cases as we move forward?
Well, we weren't surprised because we'd already reported the increasing rate of ER-positive tumors. I guess, yeah, if you don't account for those trends, you'll come up with a lower number. But the point of our methodology is that those trends are established and our new model does account for them. So I think we have an estimate that accounts for more things that we know, and so presumably it could be more useful.
How do these numbers fit in with trends over the past decade or so? Have there been increases similar to these, or how does it compare with what you've seen in the past decade or so?
Well, we use the past 18 years of breast cancer experience to make the forecast. Okay. So they're really totally consistent with that.
Marcia Taylor, midresearch.com. Two quick questions. One, can you speak to the increasing appreciation of heterogeneity in tumors, both at primary diagnosis as well as the metastatic, and does that create a paradigm shift in terms of how you are looking at markers or groups of patients? And the second is, why did you choose not to look at women from 20 to 30?
I'm sorry, I didn't hear your question. So.
Oh, sure. The first one was, can you comment on the increasing appreciation of heterogeneity in tumors, both at the primary diagnosis as well as in the metastatic state, and how that can potentially affect these numbers? And the second question is, why did you choose not to look at women from the age of 20 to 30 in these numbers?
Okay, so we didn't divide out according to other breast cancer phenotypes. That is potentially something that could be worthwhile. And the reason that we didn't analyze the 20 to 29, that's a good point. I think We should try to do something for that, but just for our models, those numbers are just relatively small to get the kind of accuracy of the signals we like to have to put out an estimate.